Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. We've got Bob Chatterjee back in the virtual studio with us today. We had an abortive attempt to run through the second half of his presentation on spinal cases some time back. But what we want to look at is pitfalls in spinal assessment, and we're going to recap a little bit on some cauda equina information because it's so important in clinic, and then we're going to move on to some other interesting stuff that Bob has to share. Bob, great to have you with us. Not much of an introduction for you, really. I mean, you've been a spinal consultant for quite some time. You've been on the show 2 or 3 times before now, I think. So people, I hope, are familiar with you. You are trained at Guy's St Thomas, and you're now at the Royal Fleet Free, is it?
Yes, I got my medical degree from Guy's in London. A little amalgamated now a little bit, but I spent most of my sort of training career in London. I then spent some time in Oxford, some time in Stanmore in North London, Cambridge doing some neurosurgery, and Norfolk and Norwich, which has got a long-established spinal deformity unit. So, as is with training, you go around a bit and learn things from different people in different places. But I'm now based in central London at the Hospital St John's Elizabeth, which is in St John's Wood, and the London Clinic, which is in Harley Street.
But you also, you're part of the Total Orthopaedics consultancy, aren't you? And we've built up quite a rapport with you and your fellow consultants down there. And I presume that, you know, part of this for you is the hope that more and more people in your catchment area will become aware of you and start referring patients.
Yeah, I just, I see these things as a way really of introducing us. I think, you know, everyone chooses to refer to people who they feel happy with and good quality advice, and you know, there's a variety within doctors like all of us. So I'm very hopeful that, you know, some people like me and value some of my opinions, and that we can develop some working relationships.
Well, I think one of the things that we've developed and learned in APM, quite different from your line of work, obviously, is that your responsiveness to clients or customers or patients is key, because you know, if they feel that they can talk to a human being, then they're much more inclined to do business with you. And what we found with Total Orthopaedics is that, you know, you've been very responsive to our requests for help, whether it's you know, presentations like this or anything else. So hopefully people will find that when they start referring patients. I should say we've already shared your presentation from today, but we'll make it available to everybody after the broadcast again, along with the graphics that came with it, because there's that really lovely graphic about cauda equina, which many people found useful. And I told you, after the last presentation on cauda, I had somebody send back in an observation that they had recently had a patient that the GP had said, no, this is not cauda equina syndrome. They'd referred them back again, and actually the GP had then referred on, the person was then sent in for surgery. So, you know, it just goes to show that this sort of education is very useful in our practices.
I'm really pleased to hear that. And it is all about, you know, no one's perfect. We're all here to learn. It doesn't matter where you are and what stage you're on in your career. But yeah, the more we share this information around, and the more that's how we all learn.
Shall I let you start off with your presentation?
So I just wanted to talk a little bit about cauda equina syndrome in the context of spinal assessment, really. I think spinal assessment is the most important thing all of us do, really, you and me, because, you know, I always say that if you don't really understand the problem, it's very hard to put it forward. You know, sometimes I think not enough thought process has gone into the sort of understanding of, you know, why someone comes to see you in clinic. There'll be a range of conditions, some sort of acute and emergent, and some less so. But I think that the condition that is probably the most familiar emergency condition in spines is cauda equina syndrome. And I just really wanted to talk a little bit about that, so that, you get a handle on it. It's not an easy condition to deal with, because it's rare and you don't see that many of them, and whenever you see things not very frequently, it always rather tests your diagnostic skills. So the first thing I wanted to say is that cord requiner syndrome is a clinical diagnosis. It is not a radiological diagnosis, although the radiology certainly helps. And cord requiner syndrome really refers to acute compression of your spinal cord, and mark that word acute. It's not something that happens over a long period of time, or rarely so. Most of the time it happens rather suddenly. So the image I've got on the right hand side there shows something that looks horrendous. That's a side-on view looking at the spine, and you'll see the light things with the black rim around them are the discs, and the grey squares are the vertebrae. And then you'll see the L4-5 region, a large black disc bulge heading over towards the right side, causing compression of the sort of grey spinal cord. You can see it like a tail sort of coming down in the middle of that picture. Now that looks horrendous, and that might be cord requiner syndrome, and it might not be cord requiner syndrome, because the trouble is, as I said, it is not a radiological diagnosis. So a condition that you'll often see a scan looking like that is spinal stenosis. And when you've got spinal stenosis, you've often got significant compression of the spinal cord. So what's the difference, I hear you say, because they look the same on the MRI scan. So it's a question of time. Spinal stenosis is something that happens over years, and as it gradually occurs over the years, what will happen is that your spinal nerve elements have got a great deal to sort of great deal of compensatory ability within them, and as a result of that compensatory ability, they can continue to function even if it looks like that there is significant compression going on, because the body's had time to react and to that and keep the nerves working well. So spinal stenosis can give you horrendous looking pictures, but may not have issues of cord requiner. Whereas to contrast that, if you get an acute disc prolapse that suddenly comes out of nowhere and suddenly starts pressing on the spinal cord, that suddenly the spinal cord and the nerves in it are suddenly seeing stars, and the spinal cord can't deal with that, and then you start to get these horrendous symptoms of cord requiner syndrome. And the thing with cord requiner syndrome is that the trouble is that you don't have much time, sadly. It's something that needs to be done sooner rather than later. And it is virtually the only thing that I will sort of get out of the bed as an emergency to do something about, because there's no question about it that the quicker you get on top of cord requiner and decompress the spine, the better it gets.
So can I ask? You said that in the slow-moving stenosis scenario, the nerve can compensate. What physically happens to them to help them compensate? Do they move, or is there some structural change around them to protect them?
No, there's no way to move to. They remain compressed. But what's happened is that the oxygenation of the nerves, because it's not been rapidly cut off, if you like, has got time to acclimatise to it. So nerve cells can survive on low oxygen tension, but not as an acute change. It's a bit like similar to altitude training. You can get used to having less oxygen at higher altitudes, but it's got to adapt to it. So if you suddenly go and do that on one day, then suddenly you'll feel desperately short of breath, and you won't have acclimatized to it. But if you do it over a slow period of time, the nerves can accommodate it to a degree.
How about this then, Bob? I've just had a message from Pip, who says that she had a patient just last week who told her that previously she had an episode of low back pain so acute, as she's described it, that she lost control of her bladder. She went to her GP, who was unconcerned, and just told her to take painkillers. Pip says she was alarmed, to say the least, and says that the patient tells her that her bladder's never been quite the same since. I don't know how long ago this instance was, I must admit.
So that would be very worrisome for me. And one of the things I sort of see, now it may be that for that particular lady that it isn't cord requiner syndrome, but the trouble is you don't know. And I always said this, as a consultant in the NHS, I expect to get lots of negative referrals sent to me. That's not something that worries me. I used to sort of get rather cross with my junior registrars when they sort of used to say, oh, well, look, I've taken a call from a GP and I don't think it's cord requiner. And I always used to reply, are you happy to put your name to that just over a telephone call? Because if you're happy to put your name in your future career to it, then go ahead. And if you think, oh, I better check the patient, then bring them in. And I would be happy if I get 10 referrals and one of them ends up being a cord requiner. I'm delighted. And the reason for that is you expect to see lots of false positives here. And if you're not seeing lots of false positives, then your threshold for referral is too low. We just don't want to miss that one disaster. And we know they'll come with a lot of other cases that are nothing of nothing. In that particular case that you just mentioned, I would certainly have been worried, because how you can sort of say that one episode of loss of control of bladder has got nothing to do with it, unless the GP did a very careful clinical examination, and he or she may have done so, and if they did it on that basis, fair enough. But if they did it over the telephone or without having seen them, I'm struggling to see how you could make the diagnosis.
Yeah, and I know
I'd send them in now though.
Sorry, say that again.
I'd still send them in now, not for cord requiner syndrome, but you need to understand why. You need to understand whether the bladder has got anything to do with the spine or not. So they would merit an MRI in my book, even if to say that it's got nothing to do with the spine. At least that's a positive piece of information, and you can send the patient to see the right sort of person. But if you're getting an episode of loss of bladder control with severe back pain, that's got to raise some alarm bells in your head.
Bob, we've said this when we previously spoke, I know, and I hesitate to say things too many times, but I just don't think you can emphasize enough here that when you get these signs or symptoms, you do refer, because as an osteopath, you can be very nervous about making this referral and having a GP or a consultant think that you're incompetent because you've referred someone who doesn't have cord requiner syndrome. But it's really reassuring to hear you say that that's what you'd expect us to do.
I definitely do. I hate that is an utter failure of medicalness, if I can put it like that. All this nonsense hierarchy doesn't exist. The only thing that counts, and the only thing that any of us are interested in, is the welfare of our patients, mine or yours. It doesn't matter. And so, if you think, I've always been like this, even when I was a junior. If you feel there's something, then surely it's just my job to look into it. And you might be right and you might be wrong, just like I might be right and might be wrong. So please refer, and people who criticise you for doing so, talking poppycock, in my opinion.
Yeah, and as you said earlier on about people putting their names to something, I think we reassured one osteopath in a previous broadcast that, if he's even mentioned cord equina syndrome in his clinical notes and he hasn't referred, he'd better have a damn good reason why he didn't.
Yeah, I think so. I think the documentation is very, very important. Even if you're getting an obstructive, a doctor or whatever on the other side of the phone, please do document that you have made the call and you've made the referral. And sadly, when I've done medical legal expert witness things in court, these things matter. So please, yes. I do feel that you are very vulnerable in primary care, because you're sort of out there really without necessarily a sort of all the legal protections you get from the NHS. So please, your time, even if they're not giving you the answer you're looking for.
Thank you. Sorry, I interrupted, and I should let you get on.
No, not at all. I just put some charts up, really, and as I said, hopefully you'll received a copy of the presentation. But just you know the symptoms, but just a few things to add to. I'm not going to sort of read through the chart, but a few things to say. So usually the first thing that you're going to get is an onset of urinary symptoms. So things like bowel, for example, come later. So if I see someone who's got loss of bowel through cord requiner, I'm already rather worried for them, because I think it's too late. So the earliest signs you see is a disturbance to the bladder, as you see in the top left corner, and it's difficult because it's the urination is different to normal, and usually what they don't know that they need to go to the loo, and that's the sort of first sign that they tend to get. So and then they have the inability to control it that comes a little later. So it's this loss of knowing that you need to go to the loo, the loss of ability to control it when you get to the loo. These are the sort of first signs that you're looking for. They often tell you about the saddle numbers as well, only because that's what they feel when they're sort of wiping their bottom with tissue paper. They can't feel it so well. So it's definitely the upper two symptoms, in terms of the chart, are what tends to present first. The lower symptoms, the bowel function, as said, comes a little later. Sexual dysfunction is there, but often a later manifestation of cord requiner. And you may well get low back pain and weakness. The difficulty with a low back pain and weakness is sometimes you're lucky and that symptom will come out of the blue, and it sort of helps you to sort of understand what's going on. But often you'll see people getting sort of this problem on the background of a pre-existing low back pain. and weakness. So it's not often easy to distinguish. Some of the things that we have up in. Sorry.
You won't be surprised that I'm getting questions coming in quite
quickly.
Sure.
Sorry.
Interestingly, Louise has said that she had cauda equina syndrome some time ago, but her problem was not loss of control, it was urine retention. Is that common?
It is common, but that's later on. So when you get to urinary retention, that's further along than we'd like it. So it'd be interesting to know if she had absolutely any disturbance in her normal urinary function before that. So when you look at cauda equina, we often talk about whether they've got any retention or not. The sign of retention is a bad sign for us. It means that the cauda equina is progressing, and we need to do about it something sooner rather than later. But usually it's preceded with some symptoms. Sorry.
Apparently she had surgery within 3 hours. She hasn't said
no question about it. Yeah.
She's okay. Jacqueline has asked for clarification. If we get somebody who we suspect cauda equina, should we call the GP or should we send them to A&E?
I think A&E probably is my better bet because it bypasses all the other nonsense. So I would probably send them to A&E. Maybe it's just sort of my experiences over life, but usually these cauda equinas, they never come in civilized hours. I don't know why, but they rarely sort of trouble you between 9 to 5 on a Monday to Friday. They're often late in the evening or whatever. I would say if you've got a good relationship with the GP, and if you think that if you're sort of not certain but you'd like someone to examine them, then you might be able to get a GP to have a look. I have to say, under the current circumstances that we're in at the moment, I'm afraid a lot of the GPs are doing things really by remote and sort of remote consultation and so forth. And this is something that you just simply cannot diagnose by remote consultation. It needs an examination. So I think certainly in the current circumstances, I think A&E is the better bet.
I've spoken to a GP, MSK specialist in the past, commented that GPs are pretty much useless at musculoskeletal medicine. And I would have kind of thought that most osteopaths and chiropractors would be better at diagnosing this than a GP.
Am I allowed to agree with you without getting into trouble?
Well, I don't think the GP. I don't mean, it's not GP's specialist topic, is it?
I think that's accurate. In all honesty, I think. Don't get me wrong. Look, GP, and my dad was a GP, so he knows I love him. GPs know tons and tons and tons of stuff about stuff that I know nothing. Okay, but if it comes to spine, no, they're not that great at it. In all honesty, they're much better at things that kill you. Things like cardiology, oncology, and so forth, but not so much spine.
Somebody's asked me whether saddle anaesthesia is always present in cauda equina.
No, not always. None of these always are. And that's one of the problems. You don't get a consistent presenting sort of picture with cauda equina. It's a varying one, and that's one of the problems with picking it up. It's often it's a change from what they're normally like as much as anything. But no, saddle anamnesis is not always there.
Okay, we've got a question which I think I raised from my own experience with you in the past. Rob has said, what do you do when A&E still dismiss a suspected cauda equina and they refuse to MRI them? And he says it's happened to him a couple of times. And you probably know Rob because he works closely with Total Orthopaedics down there in London. Rob Shanks. Yeah, I
know Rob very well. It's difficult. So from the point of view of the patient, you tell them to go somewhere else. From the point of view of yourself, you document it significantly. Often, I mean, Rob and I actually is an example of what I mean by building working relationships. I've got a working relationship with Rob, and I'm sure that Rob would have no hesitation, or I'd like to think he'd have no hesitation in calling me whatever time of day or night it was, because I will take it seriously, and he knows that. And that, as I said, it's sometimes difficult to do. So it shouldn't be the way, but for Rob, and sometimes what I've done for other colleagues of mine is that sometimes saying exactly what Rob has said, but unfortunately with my name at the end of it and the qualifications go with it, sadly gets taken more seriously than Rob's letter on his own. And I know it shouldn't be that way, but that's the real world we sometimes live in. So, well,
I guess the nice thing from your point of view is that most osteopaths and chiropractors won't be open at 2 a.m. So if they get referred at that time of day, it'll be some of the source.
Yes, but no, I think if you genuinely, Rob makes a comment that's happened. If you genuinely think it has, you call them again, or you send them somewhere else in a different A&E department, or you get hold of a hopefully friendly Dr. Omi.
Yeah.
Yeah. Okay. So so I put up here some of the sort of the symptoms that we talk about. The saddle is not always there. The pain and the incontinence numbers. So I think we've sort of covered that already. Really, these are more sort of charts, if you like, for your workplace. I wanted just on this particular one. It says in the sort of 1, 2, 3 step, just a few things. So, if it, as I think they put it beautifully, if it's a possible diagnosis, you must investigate. Now that's, for us, if you like, but it equally applies to you. If it's a possible diagnosis, you must refer. Just change the investigate to refer. And those are the symptoms that, with back pain plus disturbance of bladder plus the sort of sensory disturbance. So as you say there, it's an and or, not a have to be. And the rest of it is really for us, and in terms of hospital things, in terms of, we should be doing MRIs. There's a problem with that at the moment because a lot of hospitals don't have ability to do MRIs out of hours, but we're changing that. We've got government approval to change that. But as with many things, you have to demonstrate the problem before you can actually change it. So it's in the process of that. But we have definitely made progress on that and getting funding for every hospital to do an MRI out of hours for cord equina.
Yeah, I like those 3 bubbles at the bottom there, the 3 myths.
Yeah, I was just going to say. So I just like the sort of three myths, partly for us and partly for you. So one is that if there's no urinary retention, it's not. So as I was saying earlier, that urinary retention is often a slightly later sign by it. So I've said that, the patients who have on their way to urinary retention but haven't got there yet are the ones that you would really like to pick up on because they tend to have the best outcome. And by the time your retention is established, I'm afraid the prognosis is not so good. Anal tone, if it's normal, again, that is not a finding that has to be there. You have to put I say this to the doctors, I'm afraid, you have to do a PR examination. We say if you don't use your finger, then go to court. If you do not document a PR examination, you are going to be in big trouble. There's no query about that. That is an absolute standard of examination for us.
What are you looking for in PR examination?
You're looking for the anal squeeze. You're looking to see if they can squeeze it down on your finger, and you're looking for how good they can squeeze it for, and also the sensation in that area. But you must do it. And the last myth is really more for us. It used to be that the MRI could wait first thing in the morning, but we're now very much changing to the pattern that we want to know about it ASAP because we may well do something about it out of hours. The guidance used to be that the operation can wait till the morning on the grounds that you have a more familiar set of staff who are used to operating with you and know where the equipment is and so forth. But it's changed. We now feel that that's valuable hours lost, and that can make the difference between nerve recovery and the lack of it. Any questions about cord equina? Could I move on to rest?
The last one I have on that one is from Salome, who says, are patients likely to feel better standing up or lying down or in any other position?
Feel better in terms of pain. So in terms of neurology, usually leaning forward a little bit tends to make them feel a bit better. So that's something that you sometimes see in the patients, but that won't get rid of all the neurological symptoms. So feel a bit better in terms of discomfort and pain, sure, but in terms of would it improve the neurology, not when it's got to the stage of a cord equina.
Sure. Okay, thank you.
That's all right. So I suppose I'm going to flick really from the sort of the emergency to the rare stuff. And I was talking about pitfalls in diagnosis because it's one of the things I see a lot in my practice where really, someone, comes to see me because things aren't as good as they should be or aren't quite as they are. And I sort of, put a lot of thought over the years into trying to understand, why sometimes people have the wrong diagnosis. And I think that's sort of a number of causes for that. So one of the causes might be that there's a degree of misattribution of the signs and symptoms. So the signs and symptoms are there, but you think it's coming from one source when it's actually coming from another. I think a different eyes is a misdiagnosis where you've completely got the wrong system in the first place, and it does happen, although fortunately not frequently. Some of the things I encourage my sort of students to think about is that the MRI will often show more than one pathology. have you got the right one? And there's no, we've all got it wrong on times. I recently saw a patient where I was absolutely convinced that the problem was coming from the slip disc in the L5S1 level on the right hand side, but actually it had nothing to do with it. She did have sciatica, but it was coming from the ischiofemoral region where there was impingement of the nerve. Rare for sure, but it happens. So make sure you try to get the right pathology. Be aware of the limitations of MRIs. They don't show everything. So the MRI is not very good at SI joints. It will show you if you've got inflammatory SI joint disease, and it is sensitive at relatively picking that up. But if you've got an overloaded SI joint because of problems elsewhere or so forth, then usually it's not going to show you what you need. And MRIs, I always say you've got to remember that the sort of standard MRI is taken with you in one position and one day. It's a single snapshot. It doesn't really reflect what your pathology is like in all the different positions you can be in. And as many of your patients will tell you, the symptoms aren't there 24/7. They sometimes sort of come and go in waves. So, there are limitations with MRIs. You've got to take them with a pinch of salt. And as you all know already, but just to re-emphasize, that MRIs are not gospel truth. They show lots of things that have got absolutely nothing to do with the symptoms.
Do you think it's a problem with MRIs that generally they are not weight-bearing? I mean, does that cause
it depends how bad this. It depends on the clinical examination first, really. I think if the clinical examination really, it's the history of the clinical examination that buys the diagnosis for me, and the MRI is there to confirm it rather than the other way around. So I will use a weight-bearing MRI if I feel that the symptoms they've got are going to be accentuated on weight-bearing and therefore might show up a bit better. But I don't think that every MRI has to be weight-bearing. If they've got a very good story of spinal stenosis, then you don't need them to be weight-bearing. They'll all be there on a standard scan.
What are the sorts of things where you think a weight-bearing MRI would be normal? Or would be
spondylolisthesis for me, pars defects, spondylolisthesis where there's malalignment between the vertebrae, that might catch on a nerve root, and particularly when I see inflamed facet joints. When you see very, very inflamed facet joints, that can also promote movement that when you put them in a lying down position, you won't pick up. And the other thing is to listen to their story. So when they tell you, I ask them, what their symptoms are like in different positions. So they say to me, look, I never get it when I lie down, but I only really get it when I stand up. I'm going to want a standing MRI because it's more likely to show me the pathology. So it's a bit about what they might have and a bit about their story.
But I ought to know this, but do all MRI suites have the capability of doing weight-bearing standing MRIs?
No, hardly any do. So the vast, over 90% of all MRI centres have only got the ability to do a lying down MRI scan. So the weight bearing MRIs are few and far between. That's why you certainly won't get one on the NHS. Certainly not routinely. We were able to send people away for them, but it was designed to create as much paperwork as possible before they'd give you approval. So you'd be really unwilling to do it. Fortunately, we've got better access to them privately, but no, the majority of them don't have the facility to do that.
Can I ask you a couple of questions from our audience?
Of course.
Georgina has said she wonders if Tarlov cysts can be a differential diagnosis that obscures cauda equina syndrome. She says she has a young patient who demonstrates all the CES symptoms, but they've MRI'd and said she doesn't have it, given her physio exercises, and she's just deteriorating apparently.
So Tarlov cysts can. So first of all, for those who you don't know, so Tarlov cyst is what we call a perineural cyst. It's a cyst coming off the sheath of a nerve. Now they can be very, very large in size, and the thing with Tarlov cysts is that they are often asymptomatic, but they can be symptomatic. I've seen a lady recently who was complaining of sciatic type symptoms, and she had a massive Tarlov cyst around one of the nerve roots, and she'd been sort of effectively ignored by the NHS. She'd been told that it was nothing to do with the symptoms. But I sent her to one of my colleague neurosurgeons to marsupialise the cyst, and it improved all her sciatic symptoms straight away. Now, that to be fair, is the rarity. The majority of Tarlov cysts don't cause it, but there are certainly some of those who do. It's not a common thing, so don't get too cross with doctors for not necessarily picking it up. But for those of us who sort of purely spinal specialists, it's definitely a possibility.
I've got another one which is about cauda equina and about inability to get a full diagnosis. Christine says that she's referred patients for cauda equina investigation. They've only had a PR exam. They haven't had an MRI and they've been told they're fine. Do you think that she or we should be more forceful if that happens and say, hang on, the PR exam is not enough, they need an MRI as well?
They should know that already. I mean, you're quite right, and that it is. You're going through a phase here where we're actually trying to change the mindset. Education takes a long time to seep down through to the people who often end up making the decisions. Quite understandably, I'm sure they've got lots of other things to do, but that's why we changed the guidelines. That you should not be. If you can't just say that they're fine based on a PR examination. That's just nonsense, I'm afraid. That doesn't have to be there. So if you suspect it clinically, you should be doing an MRI. The thing always previously has been is that, oh, well, we can't get it. We need to change that so you can get it. But no, you should be more forceful because, or at least document it, if nothing else, document it. But no, the concept that you can say someone hasn't got cauda equina PR is complete nonsense.
Okay. Mel has just told me that the Bournemouth MRI Centre, which is allied to what used to be called the Anglo-European Chiropractic College and now has a longer, more complicated name, they do upright scans apparently. And Georgina talking about that last patient says she has a very large cyst, exclamation mark. So
yeah, so very large cyst can cause neural symptoms for sure. I'm afraid I've seen that. We've seen a few patients like that, and I've operated on a few of them in my time as well. So it's if it's a very, very large cyst, that makes it a bit more likely that it can cause neural symptoms. What
about these anatomical variants that I see on your slide here?
Yeah, I've got a few just to show you. If that's all right. These are some things over the years that have caught me up. So. I like telling you about all my own failures and things because it just hopefully, you get the impression that we all should be happy to discuss the things that we've got wrong. I think that's often how you learn a lot more than talking about all your successes. So a few things to show. So things misattributed system. So back pain and kidney stones. I've seen quite a few over the years where people have had problems with severe back pain. It's actually coming from a kidney stone. Kidney stones are intensely painful, really, really painful. It's one of the few things that gives you sort of, back pain type symptoms. It's usually sort of a little higher up in the back. It's not usually the low back, but more the sort of junction of middle and lower third of the backs. And often you get symptoms associated with urination. So sometimes you almost think you may have something like a cauda equina because the symptoms are partly urinary related as well as back pain related. But that's something that you'll certainly see from time to time. If you look at the picture on the right-hand side, I've put it in dotted lines, this large black thing just lying to the left of the spinal column there, and that's an abdominal aortic aneurysm. And when the aorta should be narrower than that, and when it swells up like that, it causes pressure, and that can often present as back pain. So that's something that you'll come across from time to time.
I'm curious about this. I've known people in the past who said they thought they could palpate an abdominal aortic aneurysm. Is that likely? How easy is it to palpate? You can, but only when it's very big. So you can palpate it through the front. What you feel really is you're feeling for a deep pulsation. Right. So if it's very large, and when we say very large, usually above 8 to 10 centimeters, something like that, then if you palpate deep into the abdomen, you can feel it sometimes pulsing at you. In some ways, some of this is historical, if you like. This is the way I was taught. Sadly, I'm afraid I'm showing my age here a little bit, but I was taught when half these investigations weren't that freely available, and therefore you really had to rely on your clinical skills as much as anything. I suspect that these days, history and scan tends to what happened first. But yes, you can feel it. Thank you.
Nick, I'm just going to show you a few pictures. So this is a chest X-ray. This was a patient who was complaining of neck pain, radiating over to the right shoulder, and a little bit in the sort of upper arm. And they had an MRI scan that showed irritation of the right C4 nerve root. And so I looked at it and thought, oh, well, C4 nerve root, that goes to the sort of shoulder, sort of what we call, regimental badge area on the side of the shoulder. Must be C4 nerve root irritation. So this was a mistake, that if all you recognise is nails, then everything is a nail. And what I really need to do is think a bit outside the box. And I'm very glad that a very smart radiologist, because I'd ordered a chest X-ray as well, because he had some sort of coughy symptoms, even though it wasn't quite my field. But if you look at the top of the picture here, on the left-hand side, as you look at it, can you see there's an opacity in the top? That's a tumour of the lung. It's called a Pancoast tumour. It's a little unusual because it just sits in the top of the lung, and it refers symptoms over to the shoulder and the neck area. So it right up into the base of the neck. So you don't see them very often, fortunately.
Was that central area normal, Bob?
The central area of the picture?
Yeah, there's quite a sort of a circular opacity at the top of the thoracic.
On the right?
On the right.
Look at it? Centre right. Yeah, that's the knuckle of the aorta. It's a bit calcified.
Right. Oh, I see. It's calcified.
Yeah, it's just a bit calcified. That's why you're seeing it. So beware of lung tumours, okay, with upper shoulder and neck presentation. I don't know if anyone can see anything wrong with this, but I'll give you some clues as we go along. So this patient had weird nerve symptoms that sort of weren't really typical of any particular nerve root. It was a bit of sort of numbness everywhere in the legs, a bit of pain everywhere, a bit of weakness in different areas. Sometimes when you're trying to get a diagnosis, you want to attribute it to one nerve root or something. You couldn't do that. But if you haven't studied Billy now, this is what's called a tethered cord. So if you remember, the cauda equina usually sort of commences around about the sort of L1, L2 region. So the sort of solid spinal cord then becomes just, the horse's tail, as we call it. But if you look here, can you see this is extending all the way down, right down to the L5-S1 area. So that's a congenital failure of development of the spinal cord, and you get a whole weird neurological symptoms with it. So sometimes when you look at the scan, just make sure that the cauda equina does finish where you think it finishes, and doesn't continue further on downwards. SI joint. SI joint is the chameleon of the spine, as I call it. It mimics so many things. It can mimic disc prolapses, facet joint problems, hip problems. It can radiate pain all the way down the leg. So I think it's one of those things that needs to be in your mind when you look at patients. And I think, to be honest, doctors have been a bit slower at picking this up, I think, than you guys on the whole. But they're difficult to diagnose. We always like some objective diagnosis, but the CT SPECT scan is probably the best method of diagnosing this. If you look at this picture at the bottom, can you see the left sacroiliac joint highlighted with a red arrow there, and that yellow highlighting that you don't see on the sacroiliac joint on the other side is typical of sacroiliac joint. So often your plain MR, plain X-ray, plain CT don't show an awful lot unless it's really bad. I mean, if it's really bad that it's eroded your sacroiliac joint away, then that's different. You might see it on some of those modalities. But if it's more like a biomechanical overloading, CT SPECT scan is probably the better test to go for, although it's not that widely available. I put this picture up rather just to explain to some about nerve roots, really. So sometimes you get the wrong nerve root. So on this picture here, you can see what we talk about, the sort of the lateral recess. So if you look at the blue arrows on the left-hand picture where it says traversing L5 nerve roots. Mm-hmm. So that is one area of compression, and we call that area the lateral recess or paracentral, if you like. But the nerve roots then travel laterally out through. So if you look at the sort of area where it says the neural foramen, and sort of almost guided by the sort of pink purpley lines on that picture. So the nerve root can be entrapped further out. And I've seen some operations, unfortunately, done for the wrong nerve root. So the L5 nerve root sits in the lateral recess at the L4-5 level, but it's the L4 nerve root that's traveling out on the side where the purple area is. So if you look at the picture on the right hand side, so you'll see a sort of a centrally discharge that's affecting the lateral recess where the L5 root is. But can you see that the black stuff also extends further over to where the purple designated area is on the picture? And so that's affecting L5 and L4 nerve roots. So you've got to be certain that you've got the right nerve root that you're treating, either with an injection or an operation, because otherwise you may treat one that's asymptomatic. And we see quite a lot of those nerve root errors, if you like, in terms of knowing which one to treat. This picture shows what we call a facet joint cyst, synovial cyst. So if you look at the picture on the left-hand side, you'll see these high white signals in the facet joints, and a large cyst coming out on the patient's right-hand side. And that's pressing on their nerve, and that can cause similar symptoms to sciatica, but not be due to a prolapsed disc. So there are a few sort of weird and wonderful things that you will see then, and it's important just not to sort of miss them. Cardiac pain can often be confused with left-sided arm pain, if you like. Always think of the brain and make sure that they haven't got things like multiple sclerosis. So if you're seeing neurological signs that don't quite fit everything, it may be due to problems coming from further up, and it may be due to intrinsic pathology. And what I mean by that is that a lot of things that we treat are about things pressing the nerve from the outside, whereas actually there can be problems within the nerve themselves. So there can be tumours within the nerve. We talked a little bit about nerve sheath tumours already in terms of Tarnoff cysts. You can get infections in nerve and so forth. So it doesn't always have to be something pressing on the outside. And I always say, just always remember to examine the associated joints, which I think you guys are very good at, and us perhaps are less so. So the neck problems can be from the scapula, can be from the shoulder, can be from the clavicle. Problems in the low back can be from the sacroiliac joint, can be from the hip, it can even be from the knee on occasions. So there are a number of other locations that might be causing your symptoms. So that's really all I wanted to say, really, sort of about assessment. Just want to leave a little bit of time for further questions, things. But just remember that still, for me, the history is the most important thing. That's what raises your index of suspicion about things, and taking a detailed history. That's the easiest thing to do ever, and we need to put time onto that. Chordal equine is a clinical, not a radiological diagnosis. Please do refer if you suspect, and do document it that. MRI is still the most useful way of diagnosing things, but you just have to remember that they're not infallible, and they have limitations. And don't forget to consider the rarer causes, some of which I've sort of been through with you today. So I'll stop sharing my screen there, and
Bob, that's been great. Yeah, we've not got through this presentation before because we've always had so many questions. I've got 3 more on my sheet.
Yes.
Here. Pierre has said, is there a time frame for decompression of a confirmed Culyer equina case? Nice guidelines suggest 48 hours. Is that still realistic?
No, we've changed a bit. Always be a little bit careful of NICE guidelines, okay? NICE guidelines have
one... diplomatic now, aren't you?
So say again?
You're being diplomatic in the way you phrase that.
Yes, I am, yeah. What I mean, NICE guidelines have to be delivered. So whenever you sit on the NICE guideline committee, it's not always about what is the best thing for someone, but what you can deliver in the structure you have, which isn't quite the same thing. So I think it's quite interesting. If you ask any spinal surgeon whether they would have their confirmed Culyer equina decompressed at 36 hours or 48 hours, every single one of us would say 36 hours. Time matters. And actually, although that used to be the sort of feeling that you could wait for 48 hours, no longer. As I said, it's the one thing I really would do, even if it was midnight or something. I would do it because time makes a big difference.
Okay. This is a bit off topic, but Claire has asked whether you know if thermal imaging is used for diagnosis of injuries in humans, because it's apparently quite popular in animals.
Thermal imaging?
Yeah.
Not quite. It hasn't really sort of gained a huge. All you can see with thermal imaging in humans really is you can see areas of relative high metabolism, or sometimes you can see evidence of localized trauma because of the heat that's generated from it. So it's good at picking up inflammation and trauma. I suppose the problem that we have is it doesn't tell you so much about what causes it. So it hasn't really gained an awful lot of popularity. I've seen it used in sort of more sort of human location things, in sort of, you know, mountain rescues and so forth. But that's not got so much to do with treatment of the problem, but more location of lost people.
Final question. Robin says, are there any tests or any other methods by which we can improve our diagnosis of kidney stones?
So there are a few things to say. Often probably not so easy for you to do. We often give them a shot of something called glucagon, and what it does is it significantly improves kidney stone pain, but it doesn't improve anything else. But obviously you won't be able to get hold of that. In terms of the examination, what you tend to find is that they don't have any neurological issues beyond the fact that they're not passing water very well. They're actually more due to pain rather than anything else. There's a common phrase that they say that they often feel like they're passing water, razor blades. It feels that sharply unpainful. It's a deep-seated discomfort really in the loins, and there usually isn't any specific areas of tenderness. So the examination is quite different actually from someone who's got musculoskeletal back pain. You'll find that, you know, with musculoskeletal back pain, you can put them in certain positions and it will ease some of your symptoms, whereas kidney pain is fairly unremitting. So they're different in many ways.
Well, thank you very much. We're slightly over time, and I'm very grateful for you for doing that. I think I dropped out in the middle of this. I thought it was your signal that had gone, but I think I dropped out. So I missed a little bit of what you said myself, and I'll catch that up on the recording. Great to have you on the show. Hopefully we'll get you on again sometime in the future. Orthopaedics in London, easily findable through the internet, but also we'll share that with the presentation for you after the show.